And now, as I said, I want to start with that initial trailblazer, Ingrid Scheffer. Professor Scheffer stayed up very late. I was corresponding with her at 6 o'clock in the morning our time, which was midnight her time, and Ingrid wanted to make sure that her presentation had gotten through. Professor Scheffer, as I mentioned, is the first person, along with Sam Berkovic and her team, to prove that non-inherited epilepsy can be genetic, which is, again, why we're all here. She has won a number of prizes for this research. The Australian Prime Minister's Prize for Science in Australia, the L'Oreal UNESCO Women of Science Awards for the Asia Pacific for that research. She currently goes on to do many other things, but at her heart, and I'm going to keep introductions short because Scotty isn't kidding, we are out at 5 o'clock, but at her heart, she is a clinician scientist and a pediatric epileptologist. It is my great pleasure to welcome remotely, since she unfortunately couldn't be with us in person, to welcome my friend Ingrid Scheffer, Professor Scheffer, to give us an update on KCNQ2 and to give us a 101 about KCNQ2 DEE. Ladies and gentlemen, even though it's virtual, could you give her a big round of applause? Thank you.
Good morning. Firstly, I'd like to thank Sarah for the kind introduction and Scotty and Sarah very much for the opportunity to be with you today in Denver. I wish I could be there in person, but sadly not to be. Thanks for the great topic that they've both given me, which is KCNQ2 101. So in this talk, I'm going to present the severe end of the KCNQ2 diseases with some interesting new data that has come out in recent months. And as well as that, go back to the very basics. So I apologize to those of you who've heard some of this before, but we've got to begin at the beginning and take everyone along for the ride. So here are my disclosures. Let's start by working out what KCNQ2 means. Well, K is a chemical symbol for potassium. CN simply stands for channel. Q refers to the subfamily Q of potassium channels, and 2 is the second member of the Q subfamily of potassium channels. So what does this mean? Well, the KCNQ2 is the name of the gene, and that encodes a potassium channel subunit called Kv7.2. And here you see the channel in a two-dimensional depiction lying in the cell membrane, which is this wiggly bits on the side here. And the potassium channel KCNQ2 and Q3 for that matter are made up of 6 transmembrane domains shown here that cross the cell membrane. And numbers S1 to S4, or segment 1 to segment 4, are the voltage sensing domain of the potassium channel, whereas S5, S6 and the linker between form the pore of the potassium channel. And then here you see it in a 3-dimensional depiction, and you can see here that often the potassium channel is made up of 2 different types of subunits, Kv7.2, which is KCNQ2 forms and or encodes for, and Kv7.3. Though you can also have potassium channels just made up of 4 Kv7.2 subunits. And you can see here the potassium ions go through the middle of this subunit as seen here. Now, these channels are widely expressed in the brain and nervous system, and they generate the M current. And this is a current in our neurons, our nerve cells, that regulate the resting membrane potential, and they suppress repetitive firing of neurons, so are very important in stopping seizures. So when we think about KCNQ2 diseases, we think of a broad spectrum of diseases from mild self-limited outcome diseases to severe outcome diseases. And we're going to focus here today, but just one sentence really on the self-limited neonatal seizures that have a normal outcome in terms of development and the seizures settle down, although they can be quite severe for a few weeks of life. These can be familial, and that's how the disease was first discovered, but also can occur newly in the baby before you. And then at the other end of the spectrum, we have KCNQ2 encephalopathy. Encephalopathy is just a fancy medical term for disease, pathy of the brain, so a disease of the brain. But within the KCNQ2 encephalopathies, we have now an increasing range of different presentations. And the word we use for that is called phenotypes. I'm going to spend some time on both. So KCNQ2 developmental and epileptic encephalopathy is where it's associated with a very severe epilepsy and epileptic EEG that affects brain development. But in addition to that, we now have KCNQ2 encephalopathy without epilepsy, which is where we call it a developmental encephalopathy, which is the same as saying intellectual disability. Thinking about KCNQ2 developmental and epileptic encephalopathies, and there are several of them now, I thought I should start by telling you exactly what we mean by the term developmental and epileptic encephalopathy, because this is quite complicated and often takes doctors a while to get their head across as well. So let's begin with epileptic encephalopathy. And this is where you have a lot of epileptic activity that just keeps going and sort of pummeling the brain and contributes to the child's ability to learn and often their behavior as well, but not always. And this is due to the underlying abnormality or pathology. And you can see here at the back of this, I have an EEG with constant epileptic activity, which is occurring every second of that EEG recording. And you can sort of understand that if you have a lot of epileptic activity, the child can't get on with their development. And in children with epileptic encephalopathies, we usually see you must see at some stage frequent epileptic activity. They often have very frequent seizures, but not always. They often have multiple types of seizures. And one of the key features of an epileptic encephalopathy is that it causes the child's development to slow or sometimes regress or go backwards. So we can have many different ways you can get to an epileptic encephalopathy, but the overall picture of frequent seizures, frequent epileptiform activity, and that the two together adversely impacting development so that the child slows or goes backwards. And we know that we can have an epileptic encephalopathy with a structural cause, which is not the case in KCNQ2, but here you can see all these tubers in a child with tuberous sclerosis complex, also a genetic disease. And we know that if you can figure out that one of these tubers is causing the seizures more than another, and you remove that tuber, you can actually resolve this process of epileptic encephalopathy, which is so damaging for the child. But importantly, genetic developmental and epileptic encephalopathies are an increasingly recognized cause. In fact, cause more than half of the developmental and epileptic encephalopathies. And here you see the potassium channel formed by KCNQ2 and Q3. And here in a child with KCNQ2 developmental and epileptic encephalopathy due to loss of function mutations. We know if you use carbamazepine, also known as Tegretol, and phenytoin, also used as Dilantin, these are sodium channel blockers, but we know that they're really good for this disease, and that if you can control the seizures, we hope and think today that that will improve the outcome. So just to close on this concept of a developmental and epileptic encephalopathy definition, we know that KCNQ2 causes developmental slowing and it causes an epileptic encephalopathy. So it's responsible for this condition of a combined developmental and epileptic encephalopathy. It's impossible to say which is more important in a baby with newborn onset. That's what neonatal means. And the outcome is poor, even though the seizures might settle down by 2 years of age. The children often have other problems, such as this little boy here with cerebral palsy. Autism spectrum disorder can be common, but not in this case, and also intellectual disability. Now, when we think about the developmental and epileptic encephalopathies, we have a whole spectrum of different epilepsy syndromes, and these can be well-known ones such as infantile epileptic spasm syndrome. And just to highlight that that's a new term for infantile spasm syndrome, Sarah asked me particularly to use the new terminology, which I was very involved in developing in the 2017 classification of the epilepsies. And this year we've produced 5 papers about epilepsy syndrome classification. So some of the syndromes have changed their names. We also have developmental and epileptic encephalopathies that are more in certain parts of the brain or focal. We have some beginning a bit later in life, but they can begin at any age through life. And most of them begin in the early infantile period. And just to say that these several of these syndromes, and indeed children who do not fit into a neat syndrome, have KCNQ2. But I couldn't speak about the developmental and epileptic encephalopathies without mentioning that it's a lot more than seizures. And I know that many of the parents in the audience will be already well aware of this. But seizures, development and intellectual disability, behavioural problems, gait problems, gut problems, constipation for some, swallowing problems for others, sleep problems, musculoskeletal problems such as scoliosis, and a host of other issues. And when we think about finding a precision therapy to target KCNQ2, we need to think not just about treating seizures, but treating all of these, what we call comorbidities or associated features. And often some of these features end up being much more of a problem than the actual seizures. So I want to start off with the best understood and most, equally most severe of the developmental and epileptic encephalopathies due to KCNQ2. And I was privileged to discover this entity together with Sarah Veckhausen and Peter de Jonge back in about 2012, I think. And there are now many papers on this disease, which is unfortunately not that rare. And it begins in the first week of life with tonic seizures. And here you see a little boy having a tonic seizure. You'll see in just a moment. And there's facial involvement there. Eyes are moved, facial grimacing, stiffening, and it looks very unpleasant. These children go on to develop other seizure types, often focal, tonic-clonic seizures and epileptic spasms. And here you see a baby with the early infantile form of KCNQ2, the best known form. And you can see here this left arm is jerking with a focal clonic seizure. Now here is the same little boy a bit later in life having a focal impaired awareness seizure, where you can see he has loss of awareness, head deviation up to the right with eye deviation, and now he's back with it and responding to his mum. The outcome for KCNQ2 developmental and epileptic encephalopathy is often severe to profound, although milder cases have been described, and I'll describe some of that a bit later. And autism spectrum disorder is common. They often have motor features such as hypotonia or lack of tone in the trunk. They may have spasticity like this little boy where they're stiff in the limbs, and dystonia, which is abnormal tone. The EEG in the early infantile form shows this burst suppression, bursts of epileptic activity, and then flattening of the trace, which always makes your heart sink as a neurologist, and then another burst. Or it can show multifocal epileptic activity coming from different regions of the brain, but very, very frequent, with these little dark lines delineating a second. So you can see just how frequent it is. And then in terms of KCNQ2 developmental and epileptic encephalopathy, there can be missense mutations, but also other types of mutations. And seizures may settle down, but may in fact come back later down the track. So looking at our little list of the developmental and epileptic encephalopathies I showed you before, all of these have been described now with KCNQ2 developmental and epileptic encephalopathy, but they do not all have the same functional effect. So if we think about the Ohtahara and early infantile form, they are due to loss of function of the potassium channel, And the mutations include missense, truncation mutations, and deletions. And at the other end, we have the infantile spasms syndrome, which is due to gain of function, missense mutations. So it needs to be a missense mutation in order to be associated with gain of function, but equally missense mutations can be associated with loss of function. So we need to understand the functional impact on the protein, and we also need to understand the patient's phenotype or presentation. So I want to focus now on one of the more interesting areas that has recently been discovered, which is around the gain of function phenotypes. And John Millichap, who I think is in the audience, and may with Anne later field any questions, because it'll be 2:40 a.m. in the morning here. So I'm very grateful to them for their help with this. So John described the infantile epileptic spasm syndrome, that's the new name, which is a gain of function mutation. And these babies do not have neonatal seizures, and they also can have quite a severe outcome. Mulkey and colleagues described a much more severe phenotype without neonatal seizures, but with neonatal onset of non-epileptic myoclonus and profound impairment and a very high mortality rate. And then just in the last few years, we've identified that KCNQ2 can cause a developmental encephalopathy or intellectual disability phenotype with missense mutations that can have seizures, but they're of older onset, and the outcome can still be profound, severe, or in some cases, thankfully, not quite as severe. Now, I first learned about this, I guess, feels like just over about 18 months ago, when I met this gorgeous little boy who was 3 years old, and his mum, who's a very high-level psychologist, was concerned about his development at 8 months of age. And it became clear that he has quite severe autism spectrum disorder, loves water, as you can see in this picture. He had global developmental delay, sitting just a little bit late at 8 months and walking quite late at 2 years, 11 months. He did have complex babble at 8 months, which is the normal age, but this subsequently regressed, and he's now nonverbal, but still has his complex babble. He can follow just a single command, which is associated with severe intellectual disability, and he's extremely active. So his parents really run a marathon every day looking after him. He has a range of stereotypies, which are common with children with autism, including rocking and flicking, has very significant sleep problems, and importantly, no seizures. And when I met him, he had been discovered to have a de novo, which means new in him, not present in mum or dad, KCNQ2 variant, a missense variant, alanine 3173 threonine. And I was fortunate because just prior to seeing this lovely little boy, there was this paper from Mary and colleagues where they described 4 patients without epilepsy with intellectual disability that ranged from mild to severe, with more severe speech impairment, hypotonia, autistic features and agitation in 2, as seen in my child. 1 had 3 febrile seizures, and 3 had multifocal spikes on EEG. So none of them really have epilepsy, because we don't call febrile seizures epilepsy, though this is a little bit debatable whether you should have febrile seizures at 9 years. And the MRIs were normal or showed delayed myelination. Now, this year there's been a fantastic paper from Dr. Michelli, and together with a number of my dear colleagues, Sarah, Maurizio, and Ed, who have put together a cohort that just came out a few months ago now of 15 patients, building on 5 in the literature. And these 15 patients all shared an abnormality of the same amino acid of KCNQ2, R144. And there have now been 3 different mutations described of R114, so 3 different alleles, we call that, 1 to W, 1 to Q, and 1 to G. And they've done this study of W and Q, presumably because they couldn't find any Gs. And these are 15 patients with more detailed phenotypic data. And they all showed a similar picture of delayed development, but particularly with language impairment, which goes with cognitive impairment. 40% of their 15 had infantile onset epilepsy. But despite that, 2/3 of them showed abnormal EEGs with epileptic activity and sleep that was activated. 2/3 of them had autistic features. And they made the very strong point that none had newborn seizures. So newborn period is defined as the first month of life, but as I've shown you, many of the KCNQ2 developmental and epileptic encephalopathy children begin very much in that first week of life. So no neonatal seizures, and this helps us to pull apart, does the child have a gain of function or loss of function mutational variant? And there's the clinical details from the paper. And in this paper, they showed that the R144Q, they had 6 of those patients, and their data are shown in red here, and compared them with 9 patients with R144W, again, no neonatal seizures. And looking firstly at the grade of intellectual disability, you can see the R144Q, I'm going to call them Q now, have severe intellectual disability, whereas the R144W, or the W patients, could range from mild to moderate to severe and mild here. So a much better outcome in terms of cognition. Reflecting that, language was either non-verbal or few words in the Q, but most of the patients with the W had short sentences or a few words, although you'll see there were 2 that were non-verbal. Thinking about their motor functioning, and they looked at them at the age of 3 years. Again, the Ws, many of them walked independently with only one not walking, but with the Qs, it was much more variable. Looking at behaviour, autistic features were common in the Ws, being seen in 7 of these patients, as well as ADHD being seen in 4, whereas with the Qs, this was much less common to have autistic features, but they are more severe. So it's inappropriate often to diagnose autism in someone with severe to profound impairment. So it depends a little bit on the child, or a lot on the child, really. And then turning to seizures, you can see that in the R144Qs in the red, we had 2 with childhood or infantile onset and 2 without epilepsy, whereas with the W children, they were much less likely to have epilepsy. But of course, one had childhood and one had infantile. So sadly, you can never say never. They also had sleep activation in 8 of the 12 children who had sleep recorded. And in 13 of the 14 who had an EEG, they showed posterior predominant epileptic activity, which was multifocal. MRIs were normal or showed delayed myelination. So this is a very clear demonstration of differences between the same amino acid, but different replacements of the to a pathogenic variant, one to a W and one to a Q, and they have a different phenotypic severity. They then did a very elegant discussion around and presentation of the physiology of these variants. I'm not going to go into that in detail because I'm not an expert on that, and there'll be people in the audience that will be better at this. But I've tried to put it into more simple terms, and they compared here. You can see where the different variants that they report are, that they studied, are located in the KCNQ2 protein. And you can see they looked at the variant only, they looked at the normal variant, and then they looked at the mutant variant. And I'm not going to show you the physiology curves because they are hard to follow when it's not your area, but just to show they looked at 5 gain of function variants and 2 loss of function variants. And just to show that the most severe impact, which is a negative shift of the voltage dependence of activation, which leads to a gain of function of the potassium channel. So the physiology changed so that the potassium channel is overactive, is what that means. And with your most severe presentation, the newborn profound one, they showed the most severe impact on the activation of the channel function. And then with the R144s that we've just talked about, they showed a larger impact on the one with the more severe presentation and a smaller impact. So a really nice correlation between the functional impact in the cells and the patients that we see. And then they looked at the loss of function, 2 of the recurrent mutations that we see, one causing the self-limited form with the normal outcome and one of the severe form. And then in terms of loss of function, so the opposite way, if you will, mild effect with mild outcome, severe effect with severe outcome. So finally trying to tease this apart, which is absolutely fascinating. I want to then turn to another study, which has been published just recently, of the adult phenotype of KCNQ2 DEE. And this isn't really separating it into these subgroups we've been talking about, but just to so you might look towards the future. And this is the gorgeous Jackie. So what do we see? Well, seizure types change with age, as we would expect as in epilepsy. The red denotes the infancy and childhood. The little blue line is onset under 1 year of age, and the yellow shows us the adults. So there is a picture of the tonic-clonic seizures being more prominent in infancy, childhood, and adolescence, and becoming less prominent in the adults. But these are the numbers of patients, so relatively small numbers still. Tonic seizures are also much more of an issue in the childhood cases, myoclonic more in the adult cases, and focal impaired awareness seizures become more prominent in the adult cases. The epileptic spasms are limited to childhood, but this series only had 2 adults who had had spasms, so really rather small numbers, but still begins to give us a pattern. What about, do they grow out of their seizures? Well, they do. And you can see here the ages at which they grow out of seizures by 16 to 20 years of age. That's where they've all grown out of their seizures. But there are still one having ongoing seizures at these, one growing out of seizures at 21 to 30 years and by 40 years, but there are still 3 not seizure-free. So small numbers, but still important. And of these cases, we found that more than half had severe intellectual disability, 15% mild, moderate, and profound. So a smattering, but most of them were severe. What about psychiatric problems? Well, they were a big issue in the adults with autistic features or a diagnosis of autism spectrum disorder in 10 of the patients, aggression in 4, with destructive behaviour and self-injury in 4, anxiety in 2, and only 2 had no psychiatric features. And I think the parents of the adults who are in the room might be able to tell you more about this because, well, the seizures they leave behind, or everyone gets used to managing that, these issues are quite harrowing. So I just wanted to finish in the last few minutes by talking about potential treatments, but I'm not going to spend a long time on this because I'm sure you'll hear more about that through the day. Some years ago, we described that the first-line treatment for the loss of function, developmental and epileptic encephalopathy, so the early onset babies that we first described, we use sodium channel blockers with good effect. Carbamazepine and phenytoin are both very helpful. I mentioned this earlier. And we feel that if you can stop the seizures earlier, we will have better outcomes. Very excitingly, we have a precision medicine trial underway, and this is being run by a company called Xenon of a drug called retigabine, which is a potassium channel opener or enhancer. And you see this is from one of Xenon's posters where they show that they're hoping that by enhancing the potassium channel function, they will be able to move the phenotype from the developmental and epileptic encephalopathy to the mild benign phenotype. And here you can see where they've compared the function or the effect of retigabine against the wild type or the normal. And you can see that retigabine is restoring the loss of function back towards normal function. And the aim of the randomized controlled double-blind placebo-controlled trial is to really study this and see if it can help seizures, but more importantly, outcome. And in the recent paper by Michelli and colleagues that I've talked about already, they looked at the other end of the spectrum, the gain of function phenotype. And they recognized that amitriptyline, a very well-known tricyclic antidepressant that works with serotonin and norepinephrine, we say noradrenaline over here, reuptake inhibition, and is well used in depression, migraine, and bedwetting or enuresis. They recognize that this blocks the KV channels in vitro. And this is from that paper that I've just been discussing, where they show in the mutant, the R144Q, that if you make up a channel with this or just with the normal wild type, that amitriptyline can make a big difference to inhibiting the channel. So tantalizingly, they suggest to us that amitriptyline may be worth trialing in these children. So in conclusion, KCNQ2 101, I hope I have kept it in simple terms, but it is a complex disease and a complex range of presentations and effects of the mutations or pathogenic variants. So we need to understand the presentations or phenotypes associated with loss of function and now also gain of function presentations. Before we treat a child, we need to know which we're dealing with to choose the right anti-seizure medicines. And the future is promising because we have precision medicine development underway. And I have to say, all of us that work with KCNQ2 are really excited to know that we're finally in that space. And I wouldn't like to forget to thank my wonderful team that I work with, my fantastic international collaborators, most importantly, the patients and families with whom I work, because without them, we really couldn't help to move this forward. And I'd like to thank you in the room as well for listening, but also the fantastic families, including Scotty and Sarah, and all the others that I've met when I was last with you at the last KCNQ2 conference. I hope you have a fantastic day, and I look forward to being with you, hopefully at the next meeting in person. Thank you very much for your attention.
Thank you so much, Ingrid. And we should mention that Ingrid she still has COVID. She's just gotten it. And she managed to do that presentation while she has COVID. So just again, how dedicated our professionals are. We're gonna ask questions, but before we do that, Scotty, I know you've got some people meeting with genetics counselors. Can you tell us about that?
For the families that signed up, and I know the first family is scheduled for 9:15, when you have your time slot, come and grab me real quick and I'll tell you where to meet with the counselors. It is gonna be across the street, so if you come over about 5 minutes before your slot and grab me, I'll tell you exactly where to go.
All right, perfect. All right, and we're sliding along. Does anybody have any questions? I know John Millichap has offered to do answers, Ann Baduri. Anybody have any questions you wanna ask quickly? And Claire is gonna take any from online. Claire? None from online so far. Anybody in person with any questions? Yes, there's one at the back of the room. Lynn? Do you want to come up and use the mic? We're using the mic, everyone, just because we're doing there we go. We're doing a hybrid presentation. So we're really thrilled that we have a lot of people who are joining us online. And for those who've asked, and a couple people have already, we'll be posting all of this to the website. So if you think to yourself, I really need to see that presentation one more time, you'll get the chance. Go right ahead, Lynn.
Lauren was diagnosed at 25 years old. And basically our genetic report is just the C860, that that type of report. We've never got any information on whether she's got gain of function, loss of function, and talking about the R versus W. In the UK, we have very little input to do with her genetics, her neurology. I'm just trying to find out if, you know, if there is, at her age, being an adult, there is still any value in looking into these things more. Lauren's seizure-free. She has been since 4.5 weeks old. But we have lots of other issues, health-wise and that. And I didn't know if there was anything worth pursuing to try and find out more information.
We're getting the mic on for you, John, just a sec.
I think, is it on? I think either Anne or I could answer this, maybe more the genetics, Anne, but I think you mentioned that the seizure started in infancy or at neonatal.
They say she was seizing during labour, so...
Right. So I think with my my clinical impression would be that that's a loss of function because we're not aware of any gain of functions that would start with seizures at that young age. So, but if you have the genetic report, we can also put those two pieces together, and certainly would be useful for you to know. And there might be new treatments coming along that might be specific for that variant that might help her.
I'll add that I think even though it's this many years later, it would be good to know, and I think we are not at the point of having trials for every type of condition you may have from KCNQ2 now, but we might, and it would be good to be ready. So I feel like the information can only keep us all ready, so it'd be good to pursue. And yeah, I can give you some contacts. We've been trying to sort of get the world to be smaller and smaller, so there's...
We've got a good teaching hospital in Southampton where we're from, good neurology department, good genetics, but there's never been anything fully sort of pulled together. So this person is very interested in KCNQ2 and knows a bit more. So yeah.
Yes, we'll get you some UK contacts for sure.
Thank you.
Thank you.
About how far out are the known treatments that the clinical trials start?
So Ingrid mentioned the channel openers, which would be good for loss of function, and that's really targeting seizures as the main symptom now. So for some of the very little ones, there are those targeting seizures. I think as you'll hear through the day, it's not just the seizures, and it's everything else that we want to think about as a whole set of conditions related to KCNQ2. So in terms of trials targeting those other symptoms, we're not there yet. I think we'll speculate as the day goes on, how far we might be. I think, there's a lot we've learned about KCNQ2 and all of its manifestations, and many of the people here are working on it at the bench, looking at the science. But putting those together and moving to a clinical trial that's KCNQ2 specific is, it was science fiction 10 years ago. It's actually on the chalkboard now, but I hesitate to say exactly how far we are.
Yeah, thank you so much, Anne. It's a great question, and it's one everyone wants to know. And it's exciting to be here because we're building. These are building blocks, and one builds on the other. So, we may not be able to provide all the answers right now, but in asking the questions, we're helping to create further research. And that really does bring me to our next speaker, Al George.